And we can start.
Yeah.
Yeah.
Yeah. A very good afternoon to all the delegates and the CD convener, Jashan Arora, to our speaker, Dr. Akshay Rathi, and our president, Dr. Vijay Kedar. First of all, I would like to thank all the delegates for being a part of this webinar. Also would like to thank our president, Dr. Vijay Kedar, our secretary, Dr. Virat Sangvi, CD convener, Dr. Jashan Arora, our co-hosts, Dr. Gajanan Agarwal, Dr. Kapil Golwankar, and our sponsorer, Dentex 3D, Dr. Vinayak Shirsekar, for sponsoring all our webinars. Probably this is our 22nd webinar, and a few more, not very sure if few more webinars will be conducted or no, but please stay on the group and the information of the webinars will be posted on the group. Today's speaker is Dr. Akshay Rathi, and he will be speaking on aligners. I now request Dr. Jashan Arora to kindly introduce our speaker for today.
Today we have with us Dr. Akshay Rathi, who is a Mumbai University topper and gold medalist, graduated from Government Dental College and Hospital, Mumbai. And he has done his post-graduation in orthodontics from the Nair Hospital and Dental College, Mumbai. He has received numerous scholarships during his meritorious academic career, including the IDA Awards for proficiency in orthodontics, community dentistry, and pediatric dentistry. He maintains an exclusive orthodontic practice in Juhu, Mumbai, and is also a visiting orthodontist to leading private clinics. He has presented and published several papers, the editor of Journal Gonian and the course director of OrthoTrain, a multi-module course in clinical orthodontics for general dentists since 2005. He has also conducted an advanced hands-on course in microimplants for orthodontists. He has been awarded the Beighton Award 2015 Dentistry Imprinted for his contributions in the field of dental publications. Currently, he is pursuing his fellowship from Roseman University, USA. Dr. Akshay Rathi, sir, the screen is all yours. You can start with your presentation. Thank you.
Yeah, just a minute, Dr. Akshay Rathi. First, I would just request all of you to stop your videos and mute the audios so that we do not have buffering during the webinar, and this webinar can go on smoothly. Yeah, you can start now, Dr. Akshay.
A very good afternoon to all of you. And I know you will be wishing me the same, but all of you are muted. And thank you, Jashan, for the extensive introduction that you gave me. Basically, I love my work. I love practicing orthodontics and teaching. So let me now start with the topic for today, and that is going to be on aligners.
Oh,
Now, mainly I'm going to tell you about why aligners. And then we'll follow it up with a question answer session. Is my screen visible?
Not yet, sir.
Can you?
No.
1 second. Optimize screen for. Is the screen visible?
Yes, sir.
Yeah. Shall we start? A warm welcome to all of you. And at last count, I could see more than 50 of you on this.
So
And
just a minute, please. You can just press on the minus button on the video panel because we are able to see that, and because of which the presentation is not to be seen completely.
I didn't get you. Can
The
you
minus
repeat?
button on the video panel. There's a video panel on the right hand side where you can see yourself.
Yeah.
Yes.
Yeah, I'll do that.
Yes, sir. Perfect.
It's good?
Yes, sir. Perfect. You're
Yeah.
right.
Yeah. So, good afternoon, everybody, and warm welcome to all of you. Thank you, the Mumbai West Suburban branch of IDA, for having me here to share my views. And it's nice. I am seeing more than 50 of you over here, gifted and talented young dentists. So getting enriched about newer things. So I just came to know that this is more than 20 webinars have already been conducted by you. And that's really very good. So let me begin by saying this. If you think it can be done, or if you think it cannot be done, in both these scenarios, you are always right. So it's up to you whether you have to develop the mindset that you can do a particular thing, or you can develop a mindset and be comfortable with it that you cannot do it. There is nothing right or wrong. Whatever it is, it's up to you. If you are not doing it, that is right for your clinic. If you are doing it, that is right for you and your family. Sometimes the smallest step in the right direction ends up being the biggest step of your life. Tiptoe if you must, but take these positive steps. I graduated from GDC and did my post-graduation in Nair under Dr. Wadkar. And this is the picture of my clinic at Juhu, where I do orthodontics, and my better half, Dr. Seema, does general practice with more focus on implantology. Once a month for the past 6 years, I have been visiting Oman as a consultant orthodontist, and I spend 3 days in Oman treating Omani patients over there. It's been a year since I joined Illusion Aligners as the head of training and innovation in the group of Illusion Dental. And this is my 16th year, and we are into the 36th batch of OrthoTrain, which concurred the lockdown started. So I had my first batch module from 12th to 15th of March, just a week before the lockdown got initiated. In fact, we have already cancelled, not cancelled, but postponed a couple of modules of OrthoTrain. The Oman consultation visits have been stopped for a couple of months, and so on. It's giving me sufficient time to regroup myself and go into the activities which I like the most. The first question which comes to everybody's mind is, can I practice orthodontics? Because the topic of my presentation today is aligners, and aligners comes in orthodontics. Is it legal? A lot of times I have been asked this question and asked to comment whether anybody can sue us if we practice orthodontics being general dentists. So that is the question which a lot of general dentists ask me, and I would only like to tell you that I have the answer over here, and it's not given by me, it is given by DCI. So yes, all of you who have a valid BDS degree can practice orthodontics even if you have not done your masters in orthodontics, even if you have not done any courses in orthodontics. Your BDS basically that knowledge, that degree itself is sufficient for you to practice orthodontics. And this is something which is there on the net. It is not something which I have deducted. When you'll go to the code of ethics in DCI online, you'll see that a dental surgeon can, however, practice all branches of dentistry. If you were not in a position to practice orthodontics, believe me, I would not have been able to conduct OrthoTrain, which is now in its 16th year. And every year we have 3 batches and about 35-40 dentists who train every year and go and start practicing fixed orthodontics in their practices. So if it was not legally allowed, then those dentists would have got sued. I would have got sued. I would have got debarred. But it is not like that. So it's not that the DCI prevents you from practicing orthodontics. So we come to the next question. Can I do aligners myself? Yes, you can, with a little bit more knowledge, with a little bit more application of yourself, you will be able to practice aligners in your practice and give that facility to your patients. So once again, the answer is a resounding yes. The most important question, and why Puneet and the entire gang, they asked me to conduct this seminar, is to address the question of why. Why should I add aligner therapy to my existing clinical practice when already I am doing so much of innovations in my general dentistry? I have to keep on upgrading myself with so many courses and so many advancements that take place in general dentistry. So why should I add another headache when this can be done by the orthodontist? So let me delve into this. Now, one of the most important thing that you should focus while you are treating patients is on providing a very superior level of patient satisfaction. So you should be in a position to give an extended menu of services or treatment options from which the patient can choose. You should be in a position to satisfy your patient by incorporating a wow factor into the treatment modalities. Ultimately, the best patient is a patient who is referred by your patient. And when we focus on giving the best that we can to our customers, we have increased referrals. On the technical aspects, this is the best option to lingual braces. So we must have our meter which lies in the dark green segment. We should have our patients who are extremely satisfied with the treatment and the treatment experience that they undergo in your practices. Now, whenever you want to incorporate a new discipline into your dentistry, or you want to incorporate something new, you are faced with investments. If you want to have an in-house bleaching system, then you have to invest in a light. The investment in implantology just goes on every year with new and new techniques, new armamentarium, new courses, and upgradations to the existing line of thought. Lasers, but again, an expensive modality to electrocautery, microscopic endodontics, again involving investments, piezo cutters, or if you want to incorporate a CBCT machine into your practices, all this take up a lot of investment. And what I am going to speak to you about is what you can incorporate and increase your income, not in INR, but in USD by just trying to learn and implement aligners. It's not going to take up other than your time, because the impression material you already have, or you can get an appointment and get the scanning done by the respective treatment provider to you. So this is something which you must make a conscious decision to add into your practices, which involves only application of your knowledge and no extensive gadgetry. It has one more advantage. It has an advantage that your time on the patient is reduced, whereas the time which is spent by the laboratory to provide the aligners to you is increased. So you are saving on time also. A couple of weeks earlier, I was speaking on the importance of time and to consider your income per time per hour, so that you can make out a list of few of the procedures in your practices which consume less time and give you more margins, so that you can apply the Pareto's 80-20 principle, that is 80% of your revenues come from 20% of the work you do. 80% of your revenues come from 20% of your client base. So the more you focus on high paying procedures, the upward your income graph will go. So this will give you more income per time, and that can translate into more time once you reach a comfortable level of incomes, and you can decide to spend it with a vacation or with education. You must have heard my introduction that I still invest a lot of my time and efforts into upgrading myself. I'm presently learning more about sleep apnea, about sleep medicine, about non-odontogenic sources of pain, and doing my PhD with the Roseman University under Dr. Davis Thomas. So that is something which you can think of doing, or you can just plan a retirement kitty and put in your extra income into your assets, which will continue to increase as a side ways to your active income, which is happening from the clinics. So this is all the things that I would like to share with you as to why you should try and incorporate the aligner mechanotherapy into your practices. What are the similarities between teeth and trees? And all of you would at least come up with one answer, that is both the teeth and as well as the trees, they have roots. But the similarity ends over there. Even though the teeth have roots, the teeth can be moved by the proper application of forces. So if you apply a force to a tooth which is not ankylosed, then that tooth will move over time. This is the basic premise on which the entire science of orthodontics, which is the first specialty of dentistry, is built on. That is a very simple thing which you have to understand, that if you apply force to a tooth, that tooth will move. And what we do, we apply that force in a systematic manner to move the tooth from a position of malocclusion to a position of normality. Let me go take you through a few very basic orthodontic terms, because I guess this would be your first webinar on orthodontics per se, and a lot of you have stopped in fact listening to orthodontics at any podium, because that part is handled by your consultant who comes once or twice a month to your practices. A lot of the places where I did consulting was the fortnightly or monthly session off for that general practitioner, because the entire ortho patients would be to me. So the first thing that I would like to state is that you have to understand what is normal. And only when you will know and be properly able to define the concepts of normality, will you be able to identify what is not normal. So the knowledge of normal is essential. Now, what is normal height? What is normal weight? My doctor told me that my weight is normal, but he told me that my height was not normal, because according to my weight, my height should have been another foot and a half. So it depends. Normality is not one point, but normality in a lot of cases is a mild range. This looks as a normal permanent dentation. But how do I convey this? How do I say that this incisor is placed in a proper position? This molar is placed in a proper position. This canine is best suitable for canine guidance as well as aesthetics and posterior disclusion. So I cannot just give a visual clue and say that this is what is normality. I have to define it further. So it can't be just having teeth which look very good, but we need something which has to be more accurate and more precise in giving us the definition of normality. So here we come to Dr. Lawrence F. Andrews, who has given us the criteria for normalcy in the form of the 6 keys to normal occlusion. This was something which he did as part of his thesis. When he was doing his post-graduation, he did collect individuals who had normal occlusion. 120 individuals made their impressions, made their models, cut their models into various shapes, into various angles, various parameters, and he found that these 120 individuals had something in common, and that common he gave it as the 6 keys to normality. This is something which you could apply even to your prosthetic work, even to your restorative work. So let us see what are these 6 keys to normal occlusion. The first key to normal occlusion is the molar relationship. The mesiobuccal cusp of the upper 6 must occlude with the buccal groove of lower 6. This is class 1 molar relationship. So I usually like to keep it simple. I will not call the 6 as the permanent maxillary first molar. I will just say that your mesiobuccal cusp of upper 6 should occlude with the buccal groove of lower 6. When did you first use this concept? You first used this concept when you were doing teeth setting for complete dentures. So it's not something which is restricted to orthodontics. It comes across the segments. And this is the class 1 molar relationship. When the molars are missing, we go by the class 1 canine relationship, which is that the cusp of the upper 3 falls in the embrasure between the lower canine and premolar. So the upper 3 must lie between the lower 3 and 4. These two are the basic premises of normality with respect to orthodontics. Let me come to the second highlight of the normality, which is that the teeth are not parallel to the midline. Even when you have done teeth setting, you have given the teeth a mesial tip. So the teeth, they have a mesial crown tip. And because the teeth are joined to the roots in the natural dentition, the roots go distally. So teeth have a mesial crown tip or a distal root tip. If I were to use the technical language, when you draw the long axis of the clinical crown, the incisal part of the long axis lies mesial to the cervical part of the long axis of the teeth. In a simplified manner, my teeth must not lie parallel to the midline, but they must have a mesial tip. Now look at this. We've done a lot of speaking from my end. So let me ignite your thinking button. And if this is a lateral incisor, then an upper lateral incisor, then it is of which side? Is it a right lateral incisor or is it a left lateral incisor? Look at this picture and try to identify whether this incisor is from the right quadrant or it is from the left quadrant.
From the responses in the chat box, we have got left as the answer.
Yes, that's good. So everybody is awake as of now.
Yes.
Yeah. So if this gets little heavy, please convey in your chat box and let the convener speak to me. I've tried to keep this as simple as possible. Now let us come to the third key. Third key is slightly more tricky than the first and the second ones. The third key relates with respect to the labiolingual crown inclination. This is the torque of the crown. Okay. Now this is not visible from the front. This is not visible in the oral cavity per se. This can be analyzed only when you will take a cephalogram and you will see that you don't have teeth which are perpendicular to the occlusal plane, but they are at an angulation in the labiolingual plane. Not in the, I'm not talking of the tip, which was in the mesiodistal plane. This is in the labiolingual plane, and this is referred to as the torque of a tooth. To help you identify further, this is a proper torque. If my excuse me, if my incisor moves inside, then there will be a retroclination. If my incisor becomes more labially tipped, then it becomes flaring or it becomes a proclination. So these are the various aspects of of the tip of the torque of the teeth. So we need to distinguish between the tip and the torque. So if this were the tooth, this would be the tip of a tooth. So my central incisor on the right side will be tipped like this, whereas the picture that you saw of the left incisor will be tipped like this. Now what is the torque? The torque is in this plane, the labiolingual plane. So this, you can have a normal torque, you can have a tooth which has increased torque or is proclined, and you can have a tooth which has reduced torque and is retroclined. So the teeth in the proper torque or proper labiolingual inclination are important to not only to aesthetics but also to have perfect incisal guidance. And when we go onto the molars, the torque is represented as a buccolingual position or a buccopalatal position of the premolars and the molars. So you will have the Wilson's curve, which emerges because of the torque of the molars. Let's move to the next point. This is simple. Your teeth must not be rotated. They should have the proper mesiodistal contacts with the adjoining teeth. If an anterior tooth is rotated, it interferes with the smile. If a posterior tooth is rotated, it occupies more space in the arch and it provides or it causes an interference in the cusp to fossa relationship when the upper and the lower jaws come in contact with each other. So ideally, we would want the dentition which does not have any rotations. The fifth key, and let me share this picture with you. What is wrong in this smile? This patient has got perfect tip, perfect torque, class 1 molar relationship, absence of rotations. What is wrong in her smile? There is spacing, and there shouldn't be any spacing. The fifth key to normality is that your teeth must touch the adjoining teeth and there should not be any spaces between your teeth. So this is an abnormality. What we see over here is absence of rotations and tight contacts. And coming to the sixth key, again on which I will spend some more time with you. The sixth key to normality is with respect to having a flat curve of speed. Now, what is this curve of speed? If you keep a flat surface on the occlusal surface of your lower arch, the curve of speed is measured only in the mandibular dentition. So if you keep a flat glass slab on the cast of your patient's lower dentition, then you will find some space in between the tip of the premolars and the tip of the canines and your glass slab. So that distance, the maximum distance that you get, maybe it might be with respect to the canine in some dentitions. It might be with respect to the premolars in some dentition. So that distance from the cusp tip of either the canine or the premolar and the flat surface is called as a curve of speed. So ideally, you should have a curve of speed which is flat or 1 to 2 mm. Now let me ask you the question, how will you clinically observe a deep curve of speed, or what happens in an individual, what clinical condition will your patient present with if the curve of speed is increased? So let me have your typewritten answer, and let me have the convener speak to me on this. What is the clinical manifestation of a deep curve of P? Let a sizable group put in their answers and then get back to me. Once again, I repeat the question. The normal curve of speed is flat to 1 mm. How will a deep curve of speed manifest itself in the patient's mouth?
We have different answers like deep bite, post open bite, deep bite, occlusal facets, deep anterior bite, deep bite, deep bite.
Okay. Those of you who said deep bite, congratulations to them. But let me clarify on the two other points also. What was the other two answers that you gave?
Post open bite, posterior open bite, and occlusal facets.
Posterior open bite, and second was occlusal facets. Okay.
Yeah.
Now, posterior open bite. In which condition do you get a posterior open bite? Normally, you never have a bilateral posterior open bite. The thinking is good that my anteriors are touching because of the deep curve of speed, and my posteriors will get disoccluded and there will be a posterior open bite. But in reality, that does not happen. Our brains are trained to go into what is called as MIP, or maximum intercuspation position. So if I have a deep curve of speed, then it will manifest itself as a deep bite, and the posteriors may be infra-occluded, which also contributes to the deep bite. So the deep bite could be because of infra-occlusion of the molars or supra-eruption of the incisors. In both the conditions, it is manifested clinically as a deep bite. So I hope I'm making this point clear. The second good point that somebody mentioned was the presence of wear facets. Yes, that is observed when you have a bite which got deepened because of the patient having clenching, daytime clenching or nighttime clenching, or having the habit of bruxism. So it might be that my patient is bruxing, and because of the bruxing, he or she has developed wear facets. Uh, if that patient had sufficient overjet, then those wear facets will give rise to a deep bite. If that patient does not have a sufficient anterior clearance, then the anteriors will also start getting worn off. If the anteriors are not getting worn off, then your MIP is starting to get displaced posteriorly. So of wearing of the posteriors, but those cases need not be treated with orthodontics prior to full mouth rehab or prior to reconstructing the lost tooth material. So this is how I measure a deep curve of speed or an increased curve of speed. I keep my scale or my glass slab or an occlusal mirror on the lower dentition and measure the deepest point. So these were the 6 keys to normality: the class 1 molar relationship, class 1 canine relationship, mesial tip, mesial crown tip or distal root tip, proper labiolingual and buccopalatal inclination, absence of rotations, tight contacts, and flat curve of speed. This will normally give rise to a normal overjet and normal overbite. What is overjet? Overjet is in the horizontal plane. So it's how much your upper incisor lies anterior to your lower incisor, and overbite is in the vertical plane, and that is how much vertically your upper incisor covers your lower incisor. So you can have a normal overjet and normal overbite, or you can have a deep bite with uh, anteriors covering more, or you can have an open bite. So these were few of the things that I wanted to revise with you. Now look at this cephalogram. I know that this will be Latin and Greek for you, but if you would just look at the dentition, can you guess what this patient has with the keys that I gave you? What does this patient have?
Class 3.
Yes, this patient has a class 3. Now that I could say from the models itself. So why did I need this cephalogram? And why I'm saying this is because whenever you'll be doing an aligner case, you will be collecting the OPG as well as the cephalogram of your patient. So why do I need this cephalogram? I need this cephalogram and I need to do the tracing, not by you, but it will be done by your aligner provider, whether it is a dental anomaly or a skeletal anomaly. And if at all it is a skeletal discrepancy, does the discrepancy lie in the upper dentition or in the upper arch, the maxilla, or in the lower dentition, or the lower arch, or the mandible, or a combination of maxillary deficiency and mandibular excess along with natural compensations. So there are various things that we look at when we look into the cephalogram. Good teeth are the foundation of a good smile. And why does a patient come to us? A patient comes to us because he feels that he is somewhere lacking in good looks, because the smile is not proper, because the teeth are not aligned properly, because the lips are staying open, because he's got something like a buck teeth. So these are all the problems with which the patient comes to us. And among the various treatment options that we have for these patients, one of them is aligners. We look into the vertical and various components of the normality. Now, whenever there is a departure from the normality, it constitutes a malocclusion. So here is a picture of malocclusion. But is it just that all malocclusions look like this? No, each malocclusion is different. And using the 6 keys that I gave you, we are able to identify the various components, whether it is a class 1 or a class 2 or a class 3 malocclusion, where here you can see that the is the centrals are retroclined, the laterals are proclined, the teeth do not have proper tone, there is deep bite, and so on and so forth. So what we do in orthodontics is that with the proper application of forces, we change what is existing in the patient's mouth with the teeth in abnormal positions. We apply the forces and bring the teeth to a position of normality. So With slow, sustained force, we move the teeth from a position of abnormality to a position of normality. Let me go ahead with this. Now you can all identify with the diastema. Here we have proclination and spacing. This is a condition of class 1 with the retroclined incisors and the 1-2 in crossbite, deep bite, overlap, posterior crossbite, uh, canines which are in palatally position along with an over retained C, a high frenal attachment, missing lateral incisors, and so on and so forth. So this is how we have the different aspects of malocclusion. Let me skip this part and move slightly ahead because we lost some time in the beginning. At birth, we have the gum pads. By 2.5 years, we have the deciduous dentation. And what you see over here is normality till the age of 6. This is how my patient should be. What you observe over here is spacing because the primary teeth must be smaller than the permanent teeth. Second, you have flat incisors because they are going to be worn off. You have a flush terminal plane, which by the age of 6 then goes forward into a mesial step, and you have an edge to edge bite with no overjet or no overbite. This is before the eruption of the permanent incisors. As the permanent incisors and the teeth erupt, our eruption pattern in the upper arch is 6, 1, 2, 4, 5, 3, 7, 8. And in the lower, it is 6, 1, 2, 3, 4, 5, and then 7, 8. And finally, we come to a depiction of the permanent dentition at the age of 12 with class 1 molar and class 1 canine, mesial tip, normal torque, no rotations, no spacing, and a flat curve of speed. A lot of people define orthodontics in a very complex manner. For me, orthodontics is aesthetic dentistry. What you do in aesthetic dentistry is you change the shape, the size, and the color of the teeth. In orthodontics, I do aesthetic dentistry with changing the normal positions of the teeth. Yeah, that was me before the lockdown. So we need to integrate orthodontics into our practices. These are few of my pictures of the ortho train. I will move ahead. All this is available on the net. Another session at my Juhu clinic. And the most important thing that we do in orthotrain is that we give you an exposure to live patients, and in the first module itself you are doing the fixed orthodontics on the patients. Yes, on the patients from the 3rd day onwards in the first module, and by the time you reach the last day, the time for the certification, you are familiar with most of the concepts. Of course, it's not a post-graduation, but it gives you a good working knowledge to incorporate fixed orthodontics with confidence into your practices with follow-up which takes place on WhatsApp throughout. We have been having these batches in Mumbai. we've conducted in Bhubaneswar, in Rathi, in Nasik, and there are a few other places in the pipeline. It's not a one-time program. Yes, it takes place over multiple modules, but then every 3 to 4 years, we also have update sessions for the past participants. And this group that you see over here is a group which has assembled for the update session, which takes place, uh, which is common for all the batches from batch 1 till the last batch. And these are more pictures of the same, the ortho train. And I am supported in this venture with my wife, Dr. Seema, whom you can see in the picture below there. So, friends, you can't win if you don't begin. So, the first step is to begin. What are aligners? An aligner is a clear or transparent acrylic, or maybe if I would give you the technical name, it is PET, polyethylene terephthalate, removable appliance. So an aligner is a removable orthodontic appliance manufactured on 3D printed models of the patient, covers the entire surface of the dentation and 2 millimeters of gingiva, that the patient must be instructed to wear more than 20 hours daily, and it moves teeth in a predetermined manner to correct the malocclusion sequentially. So what do we have over here? Suppose a patient comes to you with a midline diastema and you have told the patient that this midline diastema can be corrected through various methodology. You can do it with your restorative dentistry, you can do it with orthodontics, and in orthodontics you can do it with fixed orthodontic appliances, or you can do it with aligners. And this patient says that why will a patient choose aligner? A patient will choose aligner if and when that patient does not want the appliance to be seen. The patient does not want the braces to be visible. The patient wants control of the treatment in his or her hand, and the patient is educated and is financially stable enough to give you the increased cost which this premium treatment offers. So now suppose this patient is fulfilling all the criteria and she wants aligners to get the midline diastema closed. You have got two options. The first option is that you give this present to your orthodontist and say to the orthodontist, hey, look at this patient, she's ready to spend, and you take this case and do it. The other option is that you keep this patient for yourself, learn more about aligners, and try to incorporate it in a scientific as well as ethical manner into your practices. So, what will be the course of treatment for this patient? I'm taking a simple case to start with. This patient has come to you with a class 1 molar, a class 1 canine, a flat curve of spee, increased overjet, and this patient has a midline diastema, and you want to close this. So now, if you want to do it with the aligners, how will the aligners work? This case, you will send to your aligner provider and they will tell you that it will require about 8 aligners or 10 aligners or 12 aligners, whatever, and this will be the cost. Now let me go on first to the orthodontic aspect. The orthodontic aspect would be that you will be given, say, a set of 10 aligners. Now, how do these 10 aligners work? Now, and where are these 10 aligners made? So let us dissect this definition of aligners. First sentence, an aligner is a clear or transparent acrylic removable appliance. Yes, but aligner is not one appliance. Aligner is a series of appliances. So in the example that I'm taking, you have got 10 aligners. Now, these 10 aligners, are they made on the patient's impression? Are they made on the patient's models? Are they made on the patient's dies? No. These 10 aligners are made on 3D printed models of the patients. So there will be 10. Yes.
Excuse me. Are you showing any case on the screen? Because we are not able to see.
No. Right now is the slide showing the aligner.
No, that's what we are not. Only water aligners is shown, no?
Yes.
Yeah. Okay.
So let's go forward. So these patients say they have received a set of aligners. So what are these aligners going to do? If this patient has 10 aligners, then each aligner from the first aligner onwards will start moving the teeth sequentially towards the normality. And each aligner, if it were to be worn for 2 weeks, the diastema in the patient, the imaginary patient that we are considering, will get closed in 5 months. So the orthodontic aligner moves teeth without brackets, without wires, without the need of changing wires. It's a truly an invisible option which you can give to your patients, and the aligners are practically not visible at all. Now, when are aligners indicated? Aligners are of course indicated when there is a malocclusion. But how will you know that this case is good for me as a general dentist with no exposure to orthodontics to start it in my practices? So you will do this aligner therapy in your initial cases when the malocclusion is mild to moderate. For example, all cases which do not require extraction, which are cases of space closure, which are non-extraction cases of mild crowding. And the third indication which I would like to share with you is the cases which show relapse, having been treated with orthodontics few years back or at a different place or discontinued treatment. So you as a general dentist will start with your first cases when you come across cases of spacing, non-extraction cases of crowding, and cases of relapse, which may have been extraction cases or non-extraction cases where relapse has taken place either in the form of opening of spaces or of the teeth going into crowding or rotations. When are aligners not indicated? Aligners are not indicated when you have a very complex, severe skeletal malocclusion, when it's a mixed dentition, when you have complexities of surgical exposure or difficult tooth movements like intrusion, extrusion, or the rotations are more than 25-30 degrees, torquing or complex tooth movement is needed. Or if I were to give you pictorial resemblances, pictures, we would not do in extraction cases, in complex cases, in surgical exposure cases, rapid palatal expansion in mixed dentition, or a case which would require mandibular repositioning or orthognathic surgeries, microimplants. So when will it be indicated? It will be indicated when your patient has a malocclusion which falls in these three criteria. First, spacing. Second, non-extraction crowding. And third, relapse. So hope I'm able to send this message across to you that you should start aligners in your practices in a confident manner when that patient needs a non-extraction treatment which can be completed with the aligners to a reasonable degree of satisfaction. So let me go ahead and show you a case. These are the procedures that I do when I'm consulting with my patient. The last point is most important, and that is true for all your cases. Always under promise and over deliver. Aligners can be done only with rubber base impression or intraoral scanning. Alginate is not acceptable, and we need the impressions till the distal most tooth. And even if you are doing upper arch only or lower arch only, the impressions must be made or the intraoral scanning should be done for both the arches. And most aligner uh, fabricators and providers will take only the impressions and will not accept the podcasts or models. You can skip all this if you have an intraoral scanner yourself, or you can ask your aligner provider to bring the scanner for scanning. In a lot of systems, the first aligner does not move the teeth. It is referred to as the zero aligner or the fitness check aligner, where the aligner checks for the accuracy of the impression, and it gives the patient 2 weeks to get used to the aligners, which will actually start moving the teeth, and it also gives you 2 weeks to understand the further processes. A virtual post-treatment dentition, patient approval, aligner fabrication, attachments and templates. Now, because we are short of time, and this course is actually a one-day course that I conduct on aligners, which includes a lot of detailed activities, plus hands-on of attachments, plus live demonstration on patients. But here I have to condense 8 hours into 1 hour. These are steps in the attachment, but I can skip these steps because if you type attachments and Dr. Akshay Rathi in YouTube, you will get a video which shows what are attachments and how they are bonded to the teeth. Patient checkup in aligners is optional. It depends whether your patient is in-house or not. A lot of my aligner patients are non-residents, so I see them as and when they are in India. But I have one more set of patients who are in India, and I see them after a month, after 3 months regularly, and till the last aligner. What do I do? I just check that they are wearing it. I take patients' pictures, but most importantly, I motivate the patient to continue wearing the appliance and show him the pre-treatment pictures and his present condition to motivate him further. Interproximal reduction if required. And the mode of retention that I prefer, even with my aligner patients, is fixed lingual retention. So it's not that if you do a case with aligners, the retention requirement will be different than those which are treated with a ceramic appliance or a metal appliance or a self-ligating appliance. The retention will require fixed retainer. If the patient is not here for the last appointment, then you can continue the last aligner as a retainer, but make sure that now this patient is wearing the retainer for only 8 to 10 hours, because the aligner is meant to last for only 2 weeks. So you can't have an aligner retainer every 2 weeks. So reduce on the number of hours and increase on the life of the last aligner. There is only one way to completely avoid relapse at the end of the treatment. And I am not saying this. This is given by Tom Graeber. Yes, the same Graeber whose textbooks you have all read in BDS. At the end of the treatment, remove the braces, polish the teeth, make study models, take photographs. So how will you prevent relapse? That comes in the last sentence. Okay, that's the only way. Otherwise, you have to monitor the patient and see that relapse does not take place. So what is my protocol? And this is something which I will give it away to you. And this is an important take home point, is that you give a fixed lingual bonded retainer, make impressions, and give one more aligner, which will serve as a backup in case the fixed lingual bonded retainer breaks. So you can take a picture of this screen, and this will serve to remind you that this is how your retention protocol must be. So how do aligners work? Like brackets and arch wires, they move teeth. It's a revolutionary method. It was introduced in 1997-98 by Invisalign. They had their patent which expired after 14-15 years. And now we have got multiple aligner companies where the cost of aligners has come down considerably than what it was in the beginning. Yes, there are a lot of advantages. It's an aesthetic appliance. It's clear and highly transparent. What does this make? It makes this this appliance a very compliant appliance and easy to incorporate into your practices. The most important thing is you can do it yourself for the selected cases that I mentioned to you, and use it for your NRI clients, which will be typically here in the December to February region. And of course, it eliminates all the biologic points, biologic waste, and emergencies that we will need to encounter when the fixed appliance is in place. The greatest pleasure in life is doing what people say you cannot do. Let me end with a case that will show you how you can incorporate this. Now, this is my patient who was based in the Middle East, and he had already done his research on aligners and knew that aligners in India would cost him 1/3 as they would do in the Middle East. There will be 5 pictures which I will take. Front smiling, profile smiling, and 3/4 smiling. Intraoral pictures would be front, right buccal, left buccal, upper occlusal, and lower occlusal.
You can observe the generalized spacing that this patient had, and this was his major cause of concern. We got the scanning done. A couple of dentists from the aligner team, they come and take the informed written consent from the patient as well as the dentist, and this is the intraoral scanning that is taking place. So this is the first step, and then you have got the scanned records. Now these records, either in the form of scan that you see over here, or in the form of upper and lower rubber based impression that you will send to your lab. And what does that lab do? The lab distinguishes or cuts each tooth separately and moves the tooth into its correct position and sends you a virtual post treatment, which you then have to approve. Either you can do it directly, or you can call your patient for an interactive consultation and do it along with the patient. And then you get your set of transparent aligners. The first aligner is passive. This is to make sure that the patient gets used to the aligner, and the subsequent sets, they start moving the teeth in a gradual manner. So this is my patient on his fifth set of aligners. So he was in India again after about 3 months, and this is how we see this patient. We motivate the patient, do a bit of scaling, collect the records. You can see that some of the spaces are already reduced, and then this patient goes ahead and is very happy with the option. And this is what happens after the last aligner is delivered. All these spaces have closed, the proclination has reduced, the patient is comfortable, and this is how the patient smiles. This is the pre and the post of the patient. Wonderful result that we got. This is the pre and the post. Now, what the patient was seeing, what you see in the fourth quadrant picture, that is on the picture to your right. But what we see is that small spaces are still left. So at this stage, we show the patient these pictures and tell the patient that even this can be closed with the help of review aligners or finishing aligners if the patient wants. Now this patient was not interested because what this patient was seeing was not what we were observing as dentists. He was happy with his post-treatment smile. He did not take up the further review aligners. This is one more of my patient who's an actor model and who wanted an invisible option. And we went ahead and did the aligners for this patient and closed all these spaces. So this is how we progress in our practices, and it's almost more than an hour that I have been speaking to you. So let me stop the slide share for now, and let us go with the question and answer.
Yes, doctor. We have a question. Up to what age can aligners be given?
What is the question?
Up to what age can aligners be given?
Okay, that's a very interesting question. So the question is, till what age can you do aligners? And if I take it in the broader context, it will be till what age can you do orthodontics? So, when does a tooth really stop moving, or when does the periodontal ligament resolves and gets completed into ankylosed state? That never happens. So the inherent ability will remain with the patient forever, and the patient can be treated at any age. There has to be requirements of two criteria. First is that the patient should not have any active periodontal disease. So if you have a patient with good oral hygiene, that's you can continue with the treatment at any age. And the second criteria is there should not be more than 50% alveolar bone loss. So if these two criteria are satisfied, you can do aligner in a 40-year-old, in a 60-year-old, in a 70-year-old. My oldest patients are more than 60 years of age, and these patients, they want the teeth to look good, and we give them the aligners.
Okay, there's another question from Angeline. Uh, Kindly tell the materials for fixed lingual retainer.
Yes. Now, fixed lingual retainer can be done in a variety of materials. First and foremost, all materials that you do use for periodontal splinting, your resin-filled materials or your unfilled nylon strips, everything can be done with everything can be used for fixed retainers. Uh, then you can use ribbon. But what I would use and what I generally suggest is twisted ligature wire. So it consists of two strands or three strands of 0.009 or 0.010 stainless steel ligature wire, and they are twisted to form one single wire like a braid. And this is the wire that I use for fixed retention. This is the cheapest option. It is the simplest option. It does not pinch your pockets, but of course, you can use any of the periodontal splinting material.
There's another question who's they're saying, can you show how to place fixed retainer in lower after finishing the case?
A fixed retainer you would want to see in the lower arch after you have. Can you take up the next question till the
Yeah,
time I
yeah.
take this out?
Okay, there's another question. Do aligners work in extraction cases as well?
Yes, aligners have been used in extraction cases, and they are used with good effect. Uh, but the reason that I told you why you shouldn't do it in your cases which need extractions is because as an orthodontist, when I do any case, I look at plan B. If my plan A fails for some reason, there should be a plan B. Now, my plan B could be just placing a few buttons, it could be placing something aesthetic and doing the completion of the case. So, when I have a plan B and when I have explained this plan B to my patients before I am doing my plan A, then I can do it. So I use it for extraction cases, but I'm not very much fond of aligners for extraction cases. When you will go on the net, you will see a lot of cases which have been treated with aligners in the extraction cases also. But I would not really suggest you aligners your cases. If you're handing it over to the orthodontist and if the orthodontist is comfortable doing the aligner for that particular case, then you can do those cases.
Okay, and how to measure the degree of rotation of a tooth for an aligner?
Uh, Actually, you don't need to measure it yourself. You click the pictures and you send it to the aligner provider, and they themselves will scan, or they'll see the pictures and they'll be able to tell you that this case is possible or this case is not possible, and then you take a call whether you want to do it or you don't want to do it. So you don't really need to sit and measure the amount of rotation. But in case you want to measure, it is very simple. You take the upper occlusal picture, and on the upper occlusal picture, you hold a scale which will represent normality, and start moving this scale, and you will get an extent of the rotation in your particular case.
Yeah. And Dr. Reshma is asking which brands do you recommend and what will be the cost?
We have got several providers in India who will give you the who will give you with aligners. Uh, some of these will charge you on a lump sum basis and categorize that case into a case which requires few aligners to a case which requires extensive aligners, and a few of them will charge you on an aligner basis. So basically, it's up to you which aligner provider would you want to choose. Now, I work with all the aligners. I have worked with all the aligners on my patients. I find all of them to give me very good results when they are used in the properly indicated patients. Uh, I am associated with Illusion Aligners for the past 1 year, and there is some versatility when I use Illusion, in the sense that I can order aligners on a monthly basis. That means I can order 4 aligners at a time, and I have to do the payments for those 4 aligners with my monthly lab bill at the end of the month. So I don't have to block my as well as the patient's entire capital when I am doing this particular aligner. But some patients insist on Invisalign, and then we give them, which is the top of the line. But frankly speaking, it is just like you have to distinguish whether you want to buy a confident chair, or you want to buy a Tulja chair, or you want to buy an ADEC chair. It all depends on the price. The if you It depends whether you want to go from place A to place B in a Maruti or in a Honda or in a Mercedes. The basic purpose is transportation, which is satisfied by all the three. Similarly, the aligners, they have a generic mechanism of action. It's not that an illusion aligner will work differently from a flash aligner, which will work differently from an Invisalign, which will work differently from a K line or from Dent Care. All of them, they have a simple generic mechanism of action. So ultimately, the processes with which you go when you decide with a care provider with respect to any other lab, the same steps you need to follow when you are choosing the aligner brand.
Okay. And the last question for today is, after the fixed retainer, can the patient still wear the last aligner?
Yes. So, let me show you how the fixed retainer looks. 1 second. Yes, what I do is after the fixed retainer, yes. So I have this slide over here. Let me go back to slide share. Yes, so this was a case of crowding and the best option, like I told you, was this is the best option, permanent bonded lingual retainer. Here you can see a 3 to 3 with the twisted ligature wire in the lower arch and 2 to 2 in the upper arch. And the plan B is after I place this, I take measurements. This patient is based in UK. I don't want my patients to have some relapse that is taking place. So my plan B would be, in addition to this, I am giving this so that when I have multiple patients, I don't have the issue of a broken fixed retainer interfering with my treatment.
Okay. So I think with that, we have answered all the questions. If,
Yeah, there's one question: is Illusion Aligner team charging for case study?
yeah,
No. So when you take a cursory set of photographs and send it, they will tell you that this case is indicated or is contraindicated for aligners. And if it is indicated, a rough range of the number of aligners that you will need, and accordingly you can go ahead with the detailed consultation with your patient. So before we end this session, one note of positivity which I would like to instill in all of you is that this lockdown, whenever it gets over, you cannot say that it will get over on the 3rd of May, but hopefully it should get over at the earliest. But whenever you get back to practice, make sure that you are taking all the due precautions, whichever has been outlined and which has been suggested over the lot of webinars that have been taking place. Make sure that you have those PPEs, those face shields, those N95 masks with you, the sodium hypochlorite or the options which are the alcohol based or hydrogen peroxide based, and keep all these things ready and work on each patient like we were taught decade ago to work on all patients as if they are HIV positive, and now we have to work on each patient as if that patient is COVID positive. And you have to make sure that you are following all the precautions that you would take so that you don't take this thing home from with you, because it's not only your life that is important, it's the life of all your near and dear ones. uh, Yes, orthodontics is difficult to implement, but as you will see now that once I go back to practice, I am going to categorize my patients into 3 categories: grade A, grade B, grade 3, low risk, medium risk, and high risk. My low risk patients would be my patients whom I would not be taking on my dental chair, whom I would be speaking to, whom I would be reinforcing. For example, my aligner patients, for example, my patients who are on retention, for my patients who complain of some pain or discomfort, discomfort. So they will grade A patients. In your practices, it will include those patients who come to you with swelling, with pain, on which you can have a cursory look without your hand into the saliva and can prescribe these patients. So that will be your extreme low risk patients. Then will be your medium risk patients. Your medium risk patients will be the ones in which you will have an exposure to saliva but not create any aerosols. So in my practice as an orthodontist, it would be changing arch wires, it would be changing the elastics, it would be tightening the appliance. So that would be in a medium risk category. In your practices, of course, this will include the cases of excavation, your cases where you will change the RCT dressings or even extractions which are not requiring bone cutting. So that would be a grade 2 or a medium risk patient. And then there will be a high risk patient where you will always have to use an aerator. You cannot use an aerator without producing an aerosol. So all your cases which will involve cavity preparation or your cases which require a tooth preparation will require will be categorized as a high risk patient. Now these categories are not been mentioned in any of the lectures that have been taken place. These are just a few observations because as this pandemic is on, every one of us is thinking as to how we are going to go back, how are we going to start our practices. So you have the set of things which you know will be required for your personal protection and for prevention of transmission of this disease from one patient to another patient and from one patient to you and from you to a patient. So these are the precautions that you will be taking, but you must learn to categorize the risk also, and you could use your PPE sets effectively by categorizing the type of patients that you are going to treat in a session. And even in that session, you can segregate your patients going from a low risk appointments, which will be covered earlier in the session, to the medium risk patients, which will be covered after the low risk patients, and high risk patient to end that session for you, and then go ahead with a more detailed protocol of disinfection. Of course, we have to follow all the rules and regulations that have been laid down. A lot of people give a negativity that the economy is going down and from where will the patients come and how will they pay us for the treatment. But if you'll see over the past 2 months, and this I have said in earlier of my programs also and on the WhatsApp interactions also, that there's no need to go in for a negative approach, because for the past 2.5 months, the patients have even not spent their discretionary income. So the vacation has been cancelled, the outdoor goings into restaurants, into the malls, the cinema theaters, all that has come to an halt, and that is putting money into the patient's mouth also. So this is all that I would like to say before I end, because this is something important that you keep in mind. Maintain positivity. Of course, things will not come back to normal on 3rd of May. We don't know when they will come back to normal. And in fact, the concept of normality will also change. On the immediate scale, you will be working in your clinics as if you were working in an OT. So that concept of normality, which we were practicing till now, that itself is going to change. But I want to end on a happy note, on a positive note, and I am thankful to the IDA Mumbai West Suburban Branch for organizing this lecture, and thanks to all the members involved. A big thanks to the audience, and I think I can now end this session.
Thank you, Dr. Akshay Rathi. That was a wonderful presentation, and also a big thanks for those additional tips which you gave and how we can get back to our practice after this lockdown period. Big thank you for that also. So if any of the participants have any other questions, they can always post
Let
them.
me just put in my email ID or my WhatsApp number. So if there are any queries related to aligners or in general, you can WhatsApp me on this number, and I will reply. It may not be immediately, but all my WhatsApp messages are replied. Now, again, see, this is how technology moves. There was a time when you had to communicate through email, but now WhatsApp is simple, and all my participants, they stay in touch with me. All their cases are analyzed, and if they get stuck up anywhere, the WhatsApp is so convenient. So if you have any questions which may prop up when you see this video again, or when you have your first case, then this is my number and you can WhatsApp me by that time. So
Yes, sir.
yes, we shall end this session right now. Thank you all. It was wonderful to have all of you join me.
Thank you so much. Thank you to all the participants who gave their patient hearing. And if in future, if we are having any webinars, we will be putting up in the groups. So request all of you to stay in the group if you intend to listen to all these webinars. And apologies from our secretary because he couldn't conduct the webinar today. So on his behalf, I, Dr. Pratibha Shetty, was conducting this webinar. Thanks again to all of you for your patient hearing. We now end with this meeting today.